Birth after previous cesarean birth. Green Top Guideline number 45, October 2015. Definitions of terms. Planned vaginal birth after previous cesarean delivery. This refers to the intended mode of delivery of any woman who has experienced a prior cesarean birth who plans to deliver vaginally rather than by elective repeat cesarean section or ERCS. Successful and unsuccessful planned vaginal birth after previous cesarean delivery. A vaginal delivery, spontaneous or assisted, in a woman undergoing planned vaginal birth after previous cesarean delivery indicates a successful vaginal birth after previous cesarean delivery. Delivery by emergency cesarean during the labor indicates an unsuccessful vaginal birth after previous cesarean delivery. Uterine rupture. Disruption of the uterine muscle extending to and involving the uterine serosa or disruption of the uterine muscle with extension to the bladder or broad ligament. Uterine dehiscence. Disruption of the uterine muscle with intact uterine serosa. Perinatal mortality. Combined number of stillbirths, antepartum and intrapartum, and neonatal deaths between 20 weeks of gestation and 28 days of life per 10,000 live births and stillbirths. Perinatal mortality rate will exclude deaths due to fetal malformation unless otherwise stated. Term delivery-related perinatal death. Term delivery-related perinatal death is defined as a combined number of intrapartum stillbirths and neonatal deaths per 10,000 live births and stillbirths at or beyond 37 plus 0 weeks of gestation. Birth-related perinatal mortality rates exclude antepartum stillbirths and deaths due to fetal malformation unless otherwise stated. Neonatal respiratory morbidity. Combined rate of transient tachypnea of the newborn and respiratory distress syndrome. Antenatal care schedule. What is the recommended schedule of antenatal care for pregnant women with previous cesarean delivery? Implementation of a vaginal birth after previous cesarean delivery, or VBAC, versus elective repeat cesarean section ERCS checklist or clinical care pathway is recommended to facilitate best practice in antenatal counseling, shared decision-making, and documentation. In the majority of cases, counseling for mode of delivery could be conducted by a member of the maternity team soon after the woman's mid-trimester ultrasound, assuming that there were no contraindications to planned vaginal birth after previous cesarean delivery. In most cases, the decision regarding mode of delivery should be finalized by 36 plus 0 weeks of gestation. Having well-structured, evidence-based patient information leaflets that list key points, including the probability of the woman having successful VBAC, is likely to improve the informed decision-making process on mode of birth after cesarean delivery. Suitability for planned vaginal birth after previous cesarean delivery. Which women are best suited to have a planned vaginal birth after previous delivery? Planned vaginal birth after previous cesarean delivery is appropriate for and may be offered to the majority of women with a singleton pregnancy of cephalic presentation at 37 plus 0 weeks or beyond who have had a single previous lower segment cesarean delivery with or without a history of previous vaginal birth. A review of the previous cesarean delivery records and current pregnancy is recommended to identify contraindications to VBAC or vaginal birth after previous cesarean delivery. What are the contraindications to vaginal birth after previous cesarean delivery? Planned vaginal birth after previous cesarean delivery is contraindicated in women with previous uterine rupture or classical cesarean scar, and in women who have other absolute contraindications to vaginal birth that apply irrespective of the presence or absence of a scar, for example, major placenta previa. In women with complicated uterine scars, caution should be exercised and decisions should be made on a case-by-case basis by a senior obstetrician with access to the details of previous surgery. Previous uterine rupture. Women who have experienced a previous uterine rupture are reported to have a higher risk, 5% or higher, of recurrent uterine rupture with labor. Hence, previous uterine rupture is considered a contraindication to vaginal birth after previous cesarean delivery. Type of previous uterine incision. There is insufficient evidence to support the safety of vaginal birth after previous cesarean delivery in women with previous inverted T or J incisions, low vertical uterine incisions, or significant inadvertent uterine extension at the time of primary cesarean. Hence, caution should be exercised in these women and decisions should be made by a senior obstetrician on a case-by-case basis. Vaginal birth after previous cesarean delivery is contraindicated in women with previous classical cesarean delivery due to the high risk of uterine rupture. Previous uterine surgery. There is uncertainty whether women who have undergone laparoscopic or abdominal myomectomy, particularly where the uterine cavity has been breached, are at increased risk of uterine rupture. Women who have had such uterine surgery should be considered to have delivery risk at least equivalent to those of vaginal birth after previous cesarean delivery and managed similarly in labor. Placenta previa. A major degree of placenta previa, in some cases of minor or partial placenta previa, is a contraindication to vaginal delivery, including vaginal birth after previous cesarean delivery. A systematic review reported that women with 1, 2, or 3 or more previous cesarean deliveries experience a 1%, 1.7%, or 2.8% risk respectively of placenta previa in subsequent pregnancies. Placenta accreta occurs in 11 to 14% of women with placenta previa and 1 prior cesarean delivery, and in 23 to 40% of women with placenta previa and 2 prior cesarean deliveries. In women with placenta previa and 5 or more prior cesarean deliveries, the incidence of placenta accreta is up to 67%. Can women with 2 or more prior cesareans be offered planned vaginal birth after previous cesarean delivery? Women who have had 2 or more prior lower segment cesarean deliveries may be offered vaginal birth after previous cesarean delivery after counseling by a senior obstetrician. This should include the risk of uterine rupture and maternal morbidity and the individual likelihood of successful vaginal birth after previous cesarean delivery, for example, given a history of prior vaginal delivery. Labor should be conducted in a center with suitable expertise and recourse to immediate surgical delivery. The rates of hysterectomy, 56 over 10,000 compared with 19 over 10,000, and transfusion, 1.99% compared with 1.21%, were increased in women undergoing VBAC after 2 previous cesarean births compared with 1 previous cesarean birth. What factors are associated with an increased risk of uterine rupture in women undergoing vaginal birth after previous cesarean delivery? An individualized assessment of the suitability for vaginal birth after previous cesarean delivery should be made in women with factors that increase the risk of uterine rupture. Factors that potentially increase the risk of uterine rupture include short inter-delivery interval, or less than 12 months since last delivery, post-date pregnancy, maternal age of 40 years or more, obesity, lower pre-labor Bishop score, macrosomia, and decreased ultrasonographic lower segment myometrial thickness. There is uncertainty in how to incorporate this knowledge in antenatal counseling, and therefore, the presence of these risk factors does not contraindicate VBAC. However, such factors may be considered during the decision-making process, particularly if considering induction or augmentation of VBAC labor. According to the study, a myometrial thickness, the minimum thickness overlying the amniotic cavity at the level of the uterine scar, cut off of 2.1 to 4.0 millimeters, provided a strong negative predictive value for the occurrence of a uterine defect during vaginal birth after previous cesarean delivery, whereas a myometrial thickness cutoff between 0.6 and 2.0 millimeters provided a strong positive predictive value for the occurrence of a uterine defect. Antenatal counseling. What are the overall aims of antenatal counseling? The antenatal counseling of women with a previous cesarean birth should be documented in the notes. A final decision for mode of birth should be agreed upon by the woman and member or members of the maternity team before the expected or planned date of delivery. When a date for elective repeat cesarean section is being arranged, a plan for the event of labor starting before the scheduled date should be documented in the notes. The routine use of vaginal birth after previous cesarean delivery checklist during antenatal counseling should be considered, as they would ensure informed consent and shared decision-making in women undergoing vaginal birth after previous cesarean delivery. A patient information leaflet should be provided with the consultation. Up to 10% of women scheduled for ERCS or elective repeat cesarean section go into labor before 39 plus 0 weeks. It is good practice to discuss and document a plan for delivery if labor starts prior to the scheduled date. What are the risks and benefits of planned vaginal birth after previous cesarean delivery versus elective repeat cesarean sections from 39 plus 0 weeks of gestation? Women should be made aware that successful vaginal birth after previous cesarean delivery has the fewest complications, and therefore the chance of vaginal birth after previous cesarean delivery success or failure is an important consideration when choosing the mode of delivery. Women should be made aware that the greatest risk of adverse outcome occurs in a trial of vaginal birth after previous cesarean delivery, resulting in emergency cesarean delivery. Women should be informed that planned VBAC is associated with an approximately 1 in 200 or 0.5% risk of uterine rupture. Women should be informed that the absolute risk of birth-related perinatal death associated with VBAC is extremely low and comparable to the risk for nulliparous women in labor. Women should be informed that elective repeat cesarean section or ERCS is associated with small increased risk of placenta previa and or accreta in future pregnancies and of pelvic adhesions complicating any future abdominopelvic surgery. The risk of perinatal death with ERCS is extremely low, but there is a small increase in neonatal respiratory morbidity when ERCS is performed before 39 plus 0 weeks of gestation. The risk of respiratory morbidity can be reduced with a preoperative course of antenatal corticosteroids. Table number 1. Risk and benefits of opting for vaginal birth after previous cesarean delivery versus elective repeat cesarean section from 39 plus 0 weeks of gestation. Summary of outcomes of planned VBAC or vaginal birth after previous cesarean delivery versus ERCS or elective repeat cesarean section. Planned VBAC exposes the women to a very low 0.25% additional risk for experiencing perinatal mortality or serious neonatal morbidity and an additional 1.5% risk of any significant morbidity compared with opting for ERCS from 39 plus 0 weeks of gestation. What is the likelihood of vaginal birth after previous cesarean delivery success? Women should be informed that the success rate of planned vaginal birth after previous cesarean delivery is 72 to 75%. What factors determine the individualized likelihood of VBAC success? Women with one or more previous vaginal births should be informed that previous vaginal delivery, particularly previous vaginal birth after previous cesarean delivery, is the single best predictor of successful vaginal birth after previous cesarean delivery and is associated with a planned VBAC success rate of 85 to 90%. Previous vaginal delivery is also independently associated with a reduced risk of uterine rupture. Induced labor, no previous vaginal delivery, BMI greater than 30, and previous cesarean for labor dystocia are associated with an increased risk of unsuccessful vaginal birth after previous cesarean delivery or VBAC. If all of these factors are present, successful VBAC is achieved in 40% of cases. Greater maternal height, maternal age less than 40 years, BMI less than 30, gestation of less than 40 weeks, and infant birth weight less than 4 kilograms or similar lower birth weight than index cesarean delivery are associated with an increased likelihood of successful VBAC. In addition, spontaneous onset of labor, vertex presentation, fetal head engagement or a lower station, and higher admission Bishop score also increase the likelihood of successful VBAC. Successful vaginal birth after previous cesarean delivery is more likely among women with previous cesarean for fetal malpresentation, 84%, compared with women with previous cesarean for either labor dystocia, 64%, or fetal distress, 73% indications. Younger women and those of white ethnicity experience the highest success rate, in contrast to women of black ethnicity who experience a lower success rate. Those who had an emergency cesarean delivery in their first birth also had a lower VBAC success rate, in particular, those who experience a failed induction of labor.